بسم الله والصلاة والسلام على رسول الله وعلى آله وصحبه وسلم تسليما كثيرا. Our topic today regarding various forms of diabetes in children, and the topic will be, is it type 1 or type 2 or moody diabetes in children and adolescents. My name is Abdulmoein Al-Agha, Professor of Pediatric Endocrinology, Faculty of Medicine, King Abdulaziz University Hospital, Jeddah, and this presentation is available in my website aagha.kau.edu.sa. We are going, inshallah, to cover, first of all, introduction to various types of diabetes in children. What are the characters of type 1 diabetes, characters of type 2 diabetes, characters of moody diabetes, and lastly, how to differentiate between various types of diabetes in children and adolescents. First of all, pediatric diabetes is the second most common chronic illness of childhood. The second most common. And the first common one is hypothyroidism. If you look into ADA classification of diabetes in children, recent one, 2020, we find that we have type 1 diabetes is a major cause of diabetes in children and adolescents. It accounts for more than 90% of cases. So type 1 is the most common type. Every child or adolescent comes with diabetes. We have to think of type 1 till proof otherwise. But only 10% of cases might have type 2 diabetes or moody diabetes. All physicians, all pediatricians should be aware that not 100% of cases with diabetes is type 1. We have about 10% of diabetes other types than type 1. Type 2 diabetes, which is related to obesity. As you know, that obesity is becoming more and more prevalent among children and adolescents, whether in Saudi Arabia or worldwide. And because of increasing rate of obesity, we have increasing percentage of children coming with the diabetes diagnosed as type 2 diabetes. We might have less common but available present form of diabetes called moody. Moody is due to genetic defect of beta cell function. We have many subtypes of moody. We're going to discuss that, but the main principal pathology or pathophysiology of moody is genetic defect of beta cell function. And we have other types of diabetes. We have secondary diabetes and other rare forms, but the three commonest causes, type 1, type 2, and moody. All pediatricians, diabetologists should be aware of the three types, and not only to think that diabetes in children means type 1. Yes, but in 90% of cases, not always all cases of children with diabetes is type 1. Type 1 diabetes in children characterized by destruction of pancreatic beta cells because of presence of autoantibodies. But for your information, autoantibodies is positive in 95% of cases of type 1, and that is called type 1A, autoimmune mediated, while in 5% of type 1 diabetes in children have antibody negative, labeled as idiopathic type 1 or type 1B. What are the names of autoantibodies you are going to order? If you have a child, you need to differentiate, is it type 1 or type 2? We have islet cell antibody. We have antibody to GAD. We have IA2 antibody. We have antibody to insulin and antibody to zinc transporter number 8. 5 autoantibodies. You don't have to have all of the 5 positive. 2 of them is enough to make the diagnosis of autoantibody destruction of beta cells or autoimmune type 1 diabetes. But in 5% of cases, we don't have it positive despite it is type 1 diabetes. So always we have to compare clinical and biochemical results, i.e., if we have a child, thin child, with rapid onset of disease, most likely type 1 diabetes, even if autoantibodies is negative. So not always laboratory investigation is the hallmark. Both are important, clinical and biochemical. Type 2 diabetes is by far the most common type of diabetes in adulthood, but in childhood it constitutes about less than 10% of cases, and usually it's related to obesity. It is a common disorder whose prevalence rises markedly with increasing degree of obesity, in addition to positive family history. So in type 2, we have to have a positive family history of obesity and type 2 diabetes in addition to obese. Genetic and environmental factors are necessary to diagnose type 2 diabetes in children and adolescents. In children, usually we see type 2 above the age of 10 years, and the child must be overweight or obese. Patients with type 2 diabetes typically present with hyperglycemia, rarely to have decay. So diabetes ketoacidosis in type 2 occurs, but less occasionally or less frequently than type 1 children with diabetes. Very important, if we face in the emergency room a newly diagnosed child with diabetes or adolescent with diabetes, obese, to differentiate, is this child type 1 or type 2? But on the other side, if the child is thin, young, child, adolescent, no need to do autoantibody screening. It's not a usual screening test, but only we do autoantibody when we have query mark, is the child is type 1 or type 2. Autoantibodies should be done, especially anti-GAD. Anti-GAD antibody is a screening test for type 1 diabetes. but other autoantibodies is important. Type 1 diabetes usually or most commonly present with decay, while type 2 most commonly they present with hyperglycemia, although they could have decay development. Type 1 diabetes, the symptoms is more aggressive and more rapid, and they have marked weight loss. Opposite to type 2, maybe the patient is asymptomatic or discovered to have diabetes only by screening test, or they have mild symptoms of polyuria, polydipsia, but they don't have weight loss in type 2. So type 2, no weight loss. Type 1, marked weight loss before the time of diagnosis. This table will differentiate between type 1 and type 2. Type 1, usually in the history, sudden onset. The onset of the disease is sudden, usually 1 to 2 weeks history of polyuria polydipsia. And that's why most of the parents go into shock, psychological shock, when they hear that their child is having diabetes, because they said it's only 1 week. Polyuria polydipsia is only 1 week, maybe something transient. They don't think that is type 1 because it's sudden onset, while type 2 usually gradual and insidious onset. Type 1, usually the symptoms moderate to severe. Significant polyuria, significant polydipsia, significant weight loss, while in type 2, usually mild symptoms of polyuria polydipsia, and sometimes they don't have any symptoms. And they have been discovered only by routine screening. For example, entering into the school, entering into the university, going for the new job in adults, and they discover that they have diabetes. Type 1, initially, there should be positive history of marked weight loss. Type 2, usually no history of weight loss. Type 1 in thin children, type 2 in overweight or obese children. Type 1 due to autoimmune beta cell destruction, type 2 due to insulin resistance. And in type 1 there is no acanthosis nigricans, while in type 2 positive acanthosis nigricans. What is acanthosis nigricans? Acanthosis nigricans is dark, thick skin around the neck, in the axilla, and in the groin. Dark and thick skin. In type 1, ketosis prone. In type 2, ketosis may happen. So they might have ketosis, but not always. Type 1 autoantibody is positive. Type 2 autoantibody is negative. In type 1, they don't have, at time of diagnosis, they don't have enough insulin deficiency. So they will be having low insulin or low C-peptide. While in type 2, initial stage of the disease, they have insulin resistance, where the insulin level is either normal or high. Type 1 is insulin dependent, so if we didn't start insulin, the child بعد قدر الله will die because cannot survive without insulin. While type 2 could be managed without any medication. The best management of type 2 is diet and exercise, what is called lifestyle changes. Now we come to the third type of diabetes, could happen in children, what is called maturity onset diabetes of the young, MODY. Estimated prevalence of Moody worldwide is 2 to 5% of all patients with diabetes, whether children, adolescent, or adult. This disease is autosomal dominant disease, so monogenic, opposite to type 1 or type 2, type 1 and type 2 called polygenic. Polygenic means combination of environment and genetic, while in Moody only genetic factors is responsible for its development. Monogenic diabetes. First reported in 1974. Moody, a heterogeneous disorder characterized by non-insulin dependent diabetes. Onset of the disease should be any age below 25 years of age. It could not happen in person above 25 years of age as onset of the disease. That's why the name maturity onset diabetes of the young. Young means less than 25 years of age. Many patients with Moody are misclassified as having either type 1 or type 2 diabetes because a lot of pediatrician or physician, they are not much aware of this form of diabetes. So whenever they have a child or adolescent or adult with diabetes, either they classify type 1 or type 2. But in fact, 2 to 5% of these patients, they are having Moody, but nobody could recognize they have Moody. That's why, please always think of Moody as one of the types of diabetes could happen in any patient younger than 25 years of age. Regarding their body, their weight, usually they have average body weight. They are not thin, they are not obese. However, 15 to 25% of newly diagnosed patients with type 1 diabetes or Moody might be obese. So little of them or low percentage of them having obesity, but the majority, they have average body weight. For Moody, the only diagnostic or confirmatory test is by doing the genetic confirmation. That's why it is misclassified or no much cases being discovered as Moody because genetic testing is not available in many of the centers, and the diagnosis of this condition has to have positive gene mutation screening. About 80% of patients with Moody may be misdiagnosed as type 1 or type 2, as I mentioned. And when they did a review of cases diagnosed with Moody worldwide, they found that some of the cases of Moody was diagnosed after 15 years of mislabeling as type 1 or type 2. When they have genetic testing, that center, they have genetic testing, they retest these patients and they found these patients having Moody, but in the past they were labeled as type 1 or type 2 diabetes. There are several different subtypes of Moody, up to 14 subtypes. So far, 14 subtypes of Moody has been described. Each one has different genetic mutation from the other subtype. But the major types, 6. So we have 6 major types of Moody and 8 minor subtypes of Moody depending on genetic mutation. Let's see the subtypes. We have type 1 due to hepatocyte nuclear factor number 4 alpha, and it's about 10% of all cases of Moody. And this type, they need oral hypoglycemic agent to treat. They don't need insulin. Type 2, which is common form of Moody. The two most common type of Moody is type 2 and 3. Type 2, there is mutation in glucokinase gene mutation. It's about one-third of cases of Moody due to type 2. The good thing in type 2, the treatment of type 2 doesn't need oral hypoglycemic or doesn't need insulin, only diet and exercise. That's why we need to diagnose Moody and to diagnose which type or subtype of Moody, because the treatment is variable. Some of the subtypes need oral hypoglycemic, other subtype like type 2 need nothing apart from diet and exercise, and some other forms need insulin therapy. We have type 3, the commonest form is about 50 to 65% of cases. Here, due to hepatocyte nuclear factor 1 alpha. See, subtype 1 is 4 alpha, subtype 3 is 1 alpha. And here we have abnormal insulin secretion, and this type need insulin treatment. Type 4, type 5, type 6, some of them need hypoglycemic oral agent and others need insulin. So to diagnose Moody, not only to say this is Moody, not type 1 or type 2, but also the management will be different of each subtype. When to do genetic testing for Moody, when to suspect Moody. So it is important to distinguish Moody from type 1 and type 2 diabetes. Why? Because the treatment is variable as well as complication is variable. Patient with Moody due to HNF1 alpha, that is hepatocyte nuclear factor 1 alpha, type 3, or HNF4 alpha type 1 mutation are frequently misdiagnosed as having type 1 diabetes because they have some similarity between the two subtypes. The only differentiating point is genetic testing. Monogenic diabetes should be considered in any patient with diabetes who has features inconsistent with their current diagnosis. For example, they have early onset of diabetes when they were neonate, because neonatal diabetes and Moody, they are the same category of disease, but the first one, neonatal diabetes, happens in the first 6 months of life. Moody happens in any age less than 25 years of age. Or they have strong family history of Moody. We have to have at least 2 generations of patient in the family with diabetes. So Moody is autosomal dominant, need to have 2 generations with positive diabetes. And usually the symptoms of Moody is mild hyperglycemia, similar to type 2 mild symptoms. This is a good differentiating slide between type 1, type 2, and moody. Let's see the age. Type 1 diabetes happens in children less than 25 years of age, may occur at any age. Type 2 usually happens in adulthood in persons more than 25 years of age and should be obese. While moody happens in any age less than 25 years of age. So there is similarity in age between type 1 and moody. Let's look into the weight. Type 1 usually thin. Type 2 usually obese. Moody average. Most of the patients they have average body build. Autoantibodies positive in type 1, negative in type 2, negative in moody. Insulin dependent. Type 1 need insulin. Type 2 doesn't need insulin. Moody, some of the subtypes need insulin, other subtypes doesn't need insulin. Insulin sensitivity, normal in type 1, decreased insulin sensitivity in type 2, while in moody there is genetic defect of insulin synthesis rather than sensitivity. Family history of diabetes in type 1, rare, infrequent, strongly positive in type 2, and in moody should be positive and should involve multi-generation, at least more than 2 generations having diabetes. Strongly positive family history. Risk of ketoacidosis in type 1, high risk. In type 2, low risk. In moody, low risk. This is a good slide. We need to discuss it together. If you face a child or adolescent, young man or young lady less than 25 years of age, if the diagnosis was made before 6 months of age, that means neonatal diabetes, then we have to do genetic testing for neonatal diabetes to confirm neonatal diabetes, which is also a monogenic form of diabetes. If the onset of diabetes was rapid, abrupt onset diabetes, and the child was not obese, so mostly while dealing with type 1 diabetes, and usually they have autoantibody positive. But here, sometimes we are facing a child or adolescent or young man or young lady less than 25 years of age with obesity and insulin resistance, acanthosis nigricans. When we do for them antibodies to differentiate because they are young, we need to rule out type 1 diabetes, despite they are obese, but still, as I mentioned, 15% of type 1 diabetes, they have obesity. The majority, they are thin, but 15% they might have obesity. So, because of the obesity and young age group, we have to do autoantibodies. Autoantibodies positive, so they are type 1. Autoantibodies negative, we have to do genetic testing for moody. This is very important. Type 1 diabetes, as a summary, is characterized by autoimmune destruction. Type 2 is insulin resistance. And sometimes we don't have a clear cut from clinical point of view. Are we dealing type 1, type 2 moody? Then autoantibody screening to start with. Autoantibody screening positive, that will be type 1. Autoantibody screening negative, then we have to differentiate type 2 from moody by doing genetic testing. Moody classified into many subtypes, and to perform genetic testing for Moody, when we have high index of suspicion, because genetic testing is expensive, we cannot do it in any patient. We have to have high index of suspicion. What are the criteria of high index of suspicion? When we have familial sort of diabetes, we have many family members with diabetes in the family, autosomal dominant form, more than 2 generations, onset less than 25 years of age, negative antibodies. These are 3 major criteria to make you suspect of Moody and screen for genetic testing. When we have young age, less than 25 years of age, more than 2 generations in the family having diabetes, non-obese person, negative autoantibodies. Thank you very much. See you in next presentation, inshallah.